Hi, my name is Brandy Butcher, and I am doing my first assignment for the SimPath MSN Leadership and Organizational Management for the class 505. The first component kind of talks about nursing theories, and according to our rubric, the first one needed to discuss why nurse theorists create their theories. I think that nurse theorists develop theories to test hypotheses and uncover patterns that predict outcomes. So when I think of nurse theories, I think about when I was in 5th grade and I had to do a science fair project. Now I know that this is not exactly the same because we used the scientific method and they use more of a nursing method. So, but the overall design, I feel like, is very similar. So you start with a question or a hypothesis, you get the evidence, and then you analyze it so you can come up with the results, and then you either implement it or put it to a test to see if it works. And so, like, the nursing theory in my mind is just on a bigger scale. They begin with careful assessment of their patient, like observing them, collecting different data, and then from this they come up with a nursing diagnosis or hypothesis of what's happening, and then they implement it and test their ideas in real clinical settings and evaluate the results that worked and what didn't work and why. This structure of evidence-based cycle doesn't just solve immediate problems, but it builds the framework for future problems as well. I feel like each theorist is a visionary. They help to drive passion and critical thinking skills and deepen the framework for future care. Each theorist, has their own way of doing things, and they create consistent, reputable process that evaluate nursing from routine task work to a true profession, honestly. One that anticipates needs and adapts to complexity and continuously improves. So, in short, I feel like they don't just treat the patient, they shape the science and soul of nursing itself. I feel like they are able to detect patterns, and it's useful for future endeavors that we have to go through. The second one would be to categorize 3 broad categories that are used to classify the nursing theories. So far I have learned about quite a few nursing theories, but according to the University of San Diego, the website that I had looked at, they kind of classify 3 nursing theories as the grand theories, middle range theories, and practice level theories, and each plays a different unique role in advancing the profession. So the grand theories is kind of like the foundational framework for nursing as a whole. They explore concepts like person, environment, health, and nursing, and then they offer a broad philosophical lens that shapes and disciplines the identity of the worldview. The middle range theories focuses more on a narrow or specific clinical group or behavior, such as the uncertainty of an illness, transitional care, symptom management, things like that. And these theories are more observational patterns and are designed for each research and practical application in the real world. And the third one is practical level theories. So it's the most targeted of the 3. So it actually is tailored more specifically to a specific patient or a specific population or care setting or challenges that serve as a precise, actionable guide that can translate into abstract ideas, step-by-step intervention at the bedside. Together, each of those tiers create a clear progression. Like the grand theory sets the vision, the middle range theory builds on the evidence, and then the practice level theory drives daily basis care. So the expectations of practicing nurse. So I work in the emergency department. So I'm a bedside nurse, and I had done a couple other different places too. I did med surg, I did interventional radiology, critical care. I've been in the profession for quite a while, so I've had a little bit of experience in quite a few things. So as a bedside nurse, I'm going to admit to you that I don't really think about theories. It's not something that, honestly, I feel like that when I was in school, like we touched on it a whole bunch, and in my daily working environment as a nurse, I don't feel like that I think about it that much. Now, after researching this, I do feel like they are like woven into our charting and our day to day. I just didn't realize it. So I feel like every time, like every shift, I kind of use them in my like the medicine when you're doing teaching. I feel like when you are doing discharge papers, I feel like that's part of the nursing theories, because it echoes one that I was researching, the Orm's focus on self-care, and also the Virginia Henderson's 14 basic needs. So realistically, as a nurse though, I don't think that we are expected to be able to recite these theories word for word, but I think that we should recognize the fingerprints that they are leaving on the evidence-based practices in which we have adopted and adapted to our patient care. So in other words, I think that you should know at least the basics, like understand some of the theories that we use every day. So like the Orman empowers patients through self-care, Watson centers on human connection, Rory views health as adaptation, like just working familiarity versus mastering each and every one of the theories. And that way, like when you see it, you know, like, oh, well, this is, I'm putting this theory into practice. As far as intentional curiosity, I don't feel that nursing is just a task that you come in and you follow orders and you do a completion and then that's it. I think that it is always room for continuous improvement. I think that we owe it to ourselves as well as to the profession and the patients to continually, work on learning new things every day. So like whether that's a quick journal article, a podcast on your way to work, a 10-minute huddle like on new protocols to keep everybody, up to date on things. I think that would help just to keep everybody's understanding and focus on the patient and what's, the newest and latest research or evidence-based practice that we could implement to deliver the best care for our patients. And then the practical integration, we use it as the theories as a lens, not a leash. For example, we do supportive and educative system by teaching diabetic patients like carb counting for the foods that they like to eat, not necessarily like say, hey, you can't have this. It goes to show that if you are able to get with that patient and meet them where they are and work with them one-on-one and give more of an individualized care, then they will be able to have more autonomy and they will be more compliant to follow the care that you're trying to implement versus such a restriction to where they feel that it's hopeless and they're never going to be able to keep up with it. The bottom line, I feel like growth is not optional. I feel like that it is our professional responsibility, that we don't have to be theorists and we don't have to come up with reinventing the wheel, but we do need to be informed practitioners and we need to evolve with the science. We need to research, we need to reflect, and We need a lot of patient focus. I said that I think this is how we honor the depth of our profession. The importance for nurses to consider a theoretical model when providing evidence-based care. So I think that the importance of grounding evidence-based practice in the theoretical model lies in its power to connect and see connect the care and why we are doing it and for whom we are doing it. Theory does not just inspire today's protocols, it architected them, like back when Florence Nightingale, so she was like the pioneer of nursing. She didn't have protocols and government agencies, overwatching her and telling her what she could and couldn't do. So she basically helped to guide the profession as a whole, and things that we still utilize today. Of course, I'm sure that we've updated them and they're more modern, but it's all based off of back when she was doing nursing and she was caring for patients. And I feel like that every standing order that we have in our electronic health record or clinical pathway, like traces back like the lineage to a theorist's structure reasoning. Like in the emergency department, we have standing order sets. So if a patient comes in with hypertension, we can initiate a standing order set, or they come in with chest pain, we can initiate the chest pain protocol. If they come in with abdominal pain, we can initiate the abdominal pain protocol. So I think that these things are just, indispensable. But I think that, consider a patient comes in and they are diabetic. Just because a patient is here for diabetes does not mean both patients will get the exact same care. So say one patient they're in DKA, we're going to start an insulin drip and they're going to get titratable insulin. And then the other one comes in and their blood sugar may be high, but it doesn't necessarily mean that they're in DKA. We're not going to give them an insulin drip. That doesn't mean we're not going to give them insulin. It also doesn't mean that we're not going to do education with them and change things. So we may just do fluids. Their blood sugar goes down to a normal thing. And then we check their A1C, see where they're at. And maybe they're not diabetic, but they're getting close. So then we do education on diet, exercise, and things that they need to modify to change before they get to where they need to be on insulin all the time. So the differences aren't random. They stem from the framework like the Orum's self-care deficit theory, which identifies gaps in agency, or even the Roy's adaptation model, which prioritizes physiological and psychological stressors. These models are guided the original tasks, failures, and refinements, and eventually harden into evidence-based standing orders. Without the evidence-based becoming a rigid checklist, technically correct, but clinically deaf. The theory ensures that individualization with structure. So the protocols flex to the patient with the unique context. We also do predictive insight, like we anticipate the complications. If we give patient an insulin drip, then we could in turn cause hypoglycemia. If we give patients, the oral medications for diabetes, also we could cause hypoglycemia. So, and these are all things that have emerged from different theories, which is why we could see patterns and we kind of are able to critically think and be able to know maybe what could happen before and plan for it. And then, of course, ethical coherence. The care needs to remain human-centered, not just outcome-driven. Medicine is not one size fits all, and neither is nursing. Theory is kind of a bridge between population level evidence and bedside personalization, turning trial and error into reputable excellence. Some examples that I looked at. So the big one that stood out to me was Pender's health promotion model. It is a powerful real world example on the community level. So I live in a small town. It's not what I would consider rural, because I could go 15 minutes down the road and there is major hospital like Liverpool Trauma Center, but we still, even in the city, we do have a huge population that are obese, and they have hypertension and other comorbidities, obviously, that come along with being obese. And many residents are on government assisted healthcare, so, which is good that they're able to get that, but then there are a lot, like a huge population that doesn't have any healthcare insurance at all. With that being said, I have a friend who he's a nurse practitioner, and he opened a small clinic. They call it the weekend clinic. It's only open on Friday and Saturdays because he works full time Monday through Friday. I mean, it's only open Saturdays and Sundays. He works Monday through Friday. And he was able to get grants and open this clinic, and it is free of charge. He doesn't ask for proof of insurance, income, residency, nothing. There is absolutely nothing required. You go, he will see you, and he will work on getting the help that you need. So I feel like so he sees a lot of patients with hypertension, is why I bring this up. So he was able to get these patients that just walk in, he's able to give them care, and then he's even able to give them blood pressure medicine to help, with the hypertension at no cost. He doesn't charge them anything. So then that helps to remove that financial barrier and foster medication adherence, because they don't have to worry about, well, how am I going to pay for this? So it's a direct outcome to address the perceived barriers, which is part of the Pender's model. Like, it talks about that not just patient compliance, but it also talks about other barriers outside of being able to just do what you're told. So patients, like the model explains and predicts health promoting behaviors by focusing on individual cognition. Like, patients will think, is it worth all this effort, or environmental influences such as the cost or social support. In the clinic, the environment is re-engineered, care is convenient, free, and judgment-free. As a result, the patient gets to gain autonomy, not just over their blood pressure and their medication, but over the daily trade-off between survival. Like, they don't have to worry about, am I going to get my meds this month, or am I going to pay for rent, or am I going to buy food, or, all the other factors that go into it. And they can focus on their health also. Pender's framework doesn't just describe behavior, it drives intervention and design by eliminating external obstacles and boosting self-efficacy through education and follow-up. This transforms the passive patients into more active participants in their own health and wellness. This isn't a charity or anything. It is theory-guided, evidence-based community care, proving that when barriers fall, the health could rise. So that is my assignment for Sim 505, my first assignment. Thank you, and I appreciate you taking the time to watch my video.